going. Okay, time up now. We will start now, sir. Okay, good evening, everyone. Welcome to the 15th ISSH Journal Club. And all of them have been a very educative session for all of us. This month being PIP Joint Injuries Month, we have two articles which kind of discuss one of the very commonly. Welcome to the 15th ISSH Journal Club, and all of them were. So one of the we have taken two articles, and both of them discuss one of the very controversial and commonly discussed topic. One is the what treatment option we should do for PIP joint injury, and second one, the new procedure, the hemi-hamate operation, which is though a very exciting operation, but still there are some people who have reservations about it. So first Dr. Madhusudan will present about the surgical management of PIP joint injuries. This is a review of various techniques, finally trying to give some conclusions about which is good and which should be used in what type of injury. Madhusudan, over to you. And today's our guest is Dr. Sandeep Sebastian from Singapore. He is our own star who is shining in Singapore these days. And I have worked with him as one of the editors for the JHS Asia Pacific. And I have seen he has got a very nice way of analyzing article and put his conclusions very clearly. Looking forward to learning lot of things from you, sir. Okay, over to you. I will mute everyone and then you unmute yourself and start, please.
Good evening, everyone. Am I audible, sir?
Yes.
So today we are discussing a review article which talks about the outcomes of different surgical management of proximal interphalangeal joint fracture dislocations. So this was published in the journal Hand in 2021, July. The authors being Dr. Corey Damino, Megan Yates, and John Fowler. So this is from the University of Pittsburgh Medical Center, USA. So the article starts with a small introduction to the proximal interphalangeal joint, wherein it accounts for 85% of the joint motion that enables grasping an object. So any fracture dislocations or fracture subluxation will have an immense impact on the hand utility and finally resulting in a subsequent occupational disability. And hence, PIP fracture dislocations with suboptimal treatment will lead to chronic joint instability, pain, osteoarthritis, and intra-articular deformity. And with these potential complications, it will result in a hand injury that is historically been difficult to treat. So the purpose of this study is to review current literature on PIP fracture dislocations, modes of surgical repair, which includes open reduction, percutaneous fixation, dynamic external fixation, extension block pinning, and finally the hemi-hamate arthroplasty. And at the same time, to analyze validated surgical and functional outcome to determine efficacy of the numerous techniques in an acute setting. And the hypothesis is that no significant difference in patient outcome between varying surgical methods, and no method is better than other for better patient outcome across the board. So the literature search was performed using the electronic databases PubMed and Embase using the search term PIP fracture dislocation or proximal interphalangeal fracture, which was performed between 1946 to January 2019. A two-step review process was followed, wherein after reviewing the article title and abstract, only those articles meeting the eligibility criteria underwent the full text review. Only English language articles between the level of evidence 1 through 4 were included in the study, and the other inclusion criteria are those articles wherein the treatment has been done in the acute phase, that is less than 6 weeks post-injury, the articles where the type of fracture, the type of repair, and the inclusion of clinical outcome data has been mentioned. Two independent reviewers examined, after going through the entire text, collected data which includes patient characteristics, repair methods, repair metrics, and functional outcomes. And the most common outcomes which are reported were range of movement, which is reported as flexion and extension arc. And the grip strength, which is reported compared to the contralateral uninjured extremity, and finally the quick dash. A meta-analysis could not be performed due to the heterogeneity of literature collected. This is the workflow, and a total of 48 articles were finally included for the review. Out of 48 articles, 25 articles add data on dynamic external fixation, 12 on open reduction, 6 on hemihamate arthroplasty, 4 on extension block pinning, 3 on percutaneous pinning, and 2 articles add data on more than one type of surgery. And out of these 48 articles, 26 had data on dorsal fracture dislocations, 5 on pylon fracture dislocations, 1 on olar fracture dislocation, and 1 each on 2 and 3 fracture types. And this is a table containing patient characteristics in each of the 5 different surgical methods, and the columns showing number of patients or hands, the percentage of female patients, the average age of the patients, and the involved fingers. And ring finger was involved and most common in almost all the studies. The average duration between the injury to surgery and the average follow-up. And this is the table containing patient characteristics in each of the 3 different fracture types. Coming to the clinical outcomes of surgical method, this is the average range of movement and average grip strength in each of the 5 different surgical methods. And as far as the fracture type is considered, this is the average range of movements, grip strength, and quick dash in 2 common type of fracture dislocations. So from the previous table, the following inferences can be made. Number 1, the percutaneous fixation yielded the greatest average range of motion followed by open reduction, whereas the hemihamate arthroplasty yielded the lowest average range of motions. The extension block pinning methods resulted in the greatest grip strength. And coming to the fracture type, dorsal and pylon fracture dislocations had similar postoperative range of motion, whereas the quick dash score was higher when patient presented with pylon fracture dislocation, and similarly, the average grip strength was greater among the pylon fracture dislocations. So if you look at some other studies, Stern, PJ et al. Evaluated both skeletal traction and open reduction, and they found that neither surgical approach resulted in superior postoperative measures, and both approaches reported mild reduction in the PIP motion. Another study by Bergfield et al. Assessed hemihamate arthroplasty outcomes compared to the trans-articular K-wire fixation, and they concluded that both techniques were equivalent in post-surgical measurements. And in the discussion part, the authors also talks about some most common indications for each type of surgical methods, like percutaneous fixation is indicated whenever there is a large fragment without comminution, and if it fails, then open reduction can be performed. Dynamic external fixation is reserved for the highly comminuted pylon fractures, and extension block splinting for a stable and unstable dorsal fracture dislocations. And finally, the hemihamate arthroplasty, which are for the comminuted fractures involving palmar lip or lateral plateau of the middle phalanx, and it can also be used as a salvage when all the other surgical methods fail. This study also has some constraints. Though only the validated data were included, the heterogeneous composition of articles reviewed made direct comparisons challenging. Particularly, the reported measures differed between articles and resulting in difficult to perform a meta-analysis. The lack of standardized outcome measures not only resulted in reporting variability, but also in presentation of reported information. For example, some articles add grip strength compared like a percentage of the contralateral uninjured extremity, whereas other articles had grip strength measured as in kilograms. Additionally, fracture dislocation subtype was not specified in certain studies, which, if reported consistently, could have further enhanced this review. And this review article is also limited to a literature body of predominantly case series, and therefore control studies are required to assess beyond correlation. So to conclude, in this review article, the authors conclude that no surgical approach to PIP fracture dislocation management yielded consistently higher average postoperative function. And treatment of this in-joint requires a delicate decision-making that ultimately is based upon the fracture type, area of affected joint space, and size of the fracture. The authors recommend standardization of the reported outcomes like average range of motion, average grip strength, and average quick dash. The randomized controlled randomized trials always remain the gold standard, and the lack of universal and widely accepted outcome results, plus injury classification system, and at the same time relatively small incidence of PIP fracture dislocations, makes it difficult for outcome-based studies with controls to be performed. And finally, a multi-institutional study involving a standardized patient-reported outcome system would provide a stronger evidence so as to which surgical methods yields greater patient outcomes. Thank you. Thank you, everyone.
Thank you, Madhu. Very well presented, and it gives some nice conclusions. Let us see what Sandeep sir has to say about the article and also his views on what makes difference in PIP joint injuries. Is it the treatment mode or the something else? Over to you, Sandeep sir. Madhu, you remove your sharing of the screen.
Yes.
Yeah, thank you, everybody. I'd like to thank ISSH for this opportunity to talk and participate in this journal club. I feel the strength of the paper is that they have tried to do something that's very difficult. They have tried to combine different injuries and different treatment methods and give us one outcome. And that also is the weakness of the paper. I think the treatment depends on the injury, and different injuries have different outcomes. And when I read this paper, I feel we don't have any take-home message, in the sense that what they told is already out there in literature. Irrespective of the treatment method, all of them give around 80 degrees of flexion. And when they say there is a difference of 85 in one and 81, that's barely measurable even using an accurate goniometer. So that we already know. I think what we need to know is which method to choose and which feature. And they compare a wide variety of injuries with a wide variety of treatment, which may not be suitable for all PIP fracture dislocations. I think if they are just limited to dorsal fracture dislocation, which is the most common pattern, at least that would have helped us. But by including a pylon, I think they mix the injury pattern. That's one. The other criticism is that they have the range of motion only includes PIP, but I find that there is also significant loss of DIP motion, especially when you do open reduction and plate fixation. The PIP may be good, but patients cannot get their fingers down to the palm because of loss of DIP motion, and that needs to be considered in outcome measures. At the end of the day, any systematic review is based on the quality of information that's available. So because they are only looking at the outcomes that are presented in the different papers, and the vast majority of papers are case series with different outcome measuring. So the value of that systematic review is in general poor, because they are covering taking outcomes which are measured differently, surgeons who have done it differently, and injuries that are different, and trying to make sense of it. But overall, it confirms our opinion that irrespective of what you do, the range of motion is about 80 degrees. In my personal practice, if the patient moves 70 degrees, I don't do anything, because I feel it's very difficult to promise him 10 degrees of improvement with surgery. And all the treatment methods therefore come into play if the patient moves less than 70 degrees. Thank you.
Yes, sir. Thank you, sir. So actually, while selecting this paper, when we start, the topic looks very exciting. Okay, yeah, something is going to come. But finally, the conclusion comes is the same, that the fracture type, in which what is the size of the fragment, which area is involved, and what is the duration of injury is only going to make the difference. So finally, it looks like you have not added anything more to our knowledge. And more so, it is more confusing, which appears like as if percutaneous fixation is the only correct treatment, but that is not the correct way, because the fracture pattern and also at what time patient coming, that also makes so much of difference. So I was also not sure how they mixed all the things, because many of the treatment modalities are not possible. Suppose a patient is coming at 3 to 4 weeks, then it is not possible to do a K-wire fixation anyways. So that was the main doubt. So Madhu, you had any doubt while preparing? Anything you had any doubts to ask?
No, so mainly it's because of heterogeneity, sir. When we go through the entire article, lot of heterogeneity. And actually, they had a lot of papers, articles mainly on the dorsal fracture dislocations. So they could have had articles only having dorsal fracture dislocation, because there are only 5 articles with pylon fracture dislocation. They could have eliminated those 5 and had a better study with only dorsal fracture dislocation. That is one thought. And mainly the heterogeneity, so they could not make a meta-analysis also because of that. But otherwise, at the end of the paper, it's like no major information that can be derived from the paper. That's what I thought, sir.
I was also thinking, sir, there should be some paper which analyzes all the treatment modalities in first 2 weeks. So then only some kind of comparison or some kind of information as which is going to be useful can come out. So we have one hand raised from Anil Bhatt, sir, I think. So I think there is one question coming from Dr. Anil.
Praveen, can I ask?
Sir, yes, sir. Please ask, sir. Welcome, sir.
Welcome. This one for Sandeep. Sandeep said 70 is the cutoff for him when he wants to treat or not treat. So is it any specificity for that, any particular finger for that matter, when the range of motion is less? I mean, generally, I agree with Sandeep that beyond that, we really promise too much of moments. But personally, I see patients, especially with ring and index, they don't really, complain too much with that restriction. They're quite happy to do most of their work. But when it comes to middle finger, they always come back asking for a little more moments. I think it just sticks out in the middle there, and then they feel very awkward there. And so they're not happy with that. But when it's the border digits, they're not very concerned about their fist making, and they do most of the activities. So Sandeep, you have any preference of any finger, or it's just that all fingers 70 degrees okay?
Oh, I haven't given it that much thought. Like no, all fingers are the same.
Okay.
I just think that it's already quite. I came up to the 70 degree because when you are trying to teach somebody, I think you have to tell them a number, and you have to decide when should you operate or when should you not operate. And I felt that this is already so confusing so I was trying to make some sort of simplistic algorithm. And I thought that every paper I see has 80 degrees, which I think is actually 80, 85 is fantastic. All my patients don't get 80, 85 degrees. So I thought if the patient is moving 70 degrees, you are trying to promise him that you will make it 80 degrees. I thought that was very challenging. Then when you start teaching, if you say middle finger, you should different index finger, I think it just becomes even more difficult. So I just
that's been my personal experience of seeing patients where they specifically come for that. I agree with the 70 to 80 kind of thing. Most of them really don't want more, even if you tell them. But very specifically, they come and ask. Especially most of the young patients, they come back, and majority we've seen are for the middle finger. Recently we had one finger patient, ring finger, almost arthritic, young patient, just not bothered. He said, no, sir, he just came for implant for the other side. And when I asked him, he said, no, I don't want anything for that. And this is what we've been seeing for border digits, especially. That's the only question I had.
Yes, sir. So in acute settings, sir, if the patient is moving around 70 degrees, so do you offer some treatment for them, like kind of any traction device or any splintage, or you just encourage them to increase the range of movement by doing active mobilization?
Provide them with a body strap.
Body strap and move.
Yes. So if it is not subluxed, I will provide them with a body strap and move. If it is subluxed, then I'll provide them with the extension block, splint and move. Usually I will start moving at 5 days. So if I happen to see them in day 2, day 3, then we will wait for the pain and edema to subside for about a week. And after that, start moving. But usually we see them at a week because they would have come to emergency on the date of injury. And 1 week later, they come to our clinic. At that point, I would give them a body strap and move.
Okay, sir. So just to give a little bit more clearer picture to everyone. So in an acute setting, if you have a patient who has got a subluxation of the PIP joint, it is the commonly as around 30 to 40% of the articular surface is involved. Patient has primarily come to us. So what is your schedule of managing that person? What is your most preferred way of managing this injury? Just in first week of injury, 30 to 40% of the articular surface of the base of middle phalanx is damaged, and there is a post-dorsal subluxation.
So then I will still ask them to move the finger. I don't worry about the subluxation. If the patient cannot move the finger, then I will give them a local anesthesia block and see whether they can still move the finger. If in spite of the block, they cannot move the finger, we have a fluoroscopy machine in clinic. So what I will do is I will flex the finger to 30 degrees and see whether that corrects the subluxation and they can move it after that. So if they require more than 30-degree flexion, or even after correction of the finger to 30 degrees of flexion, they cannot flex it further, then I will consider surgery. At that time, I will decide between external fixation and open reduction and plate or screw fixation, depending on the size of the fragment, etc. I will also use the opportunity to do traction on the finger. And when I do traction, I try and see whether the volar lip or the middle phalanx can become at the same level or palmar to the head of the proximal phalanx on traction. And if that happens, I will consider a Suzuki frame. There have been opportunity where even after putting the frame and putting the reduction wire, the joint is still subluxed, in which case after the frame is on, I will open up and plate fix it. But most of the time, you should be able to get away with either a frame or plus minus a plate, depending on the circumstance. Occasionally, the fracture is very comminuted, or they present late, in which case I would consider hemihamate. But a hemihamate, we don't do that frequently in our setting because the patients are usually seen earlier.
Yes, sir. Yes, sir. That's what we wanted. So you you say that you see and you give a local and see how, if they are first itself moving, then there is no need to give anything, and we put a buddy strap and ask them to move. If patient is not able to move, we give a local and see how much they are moving. We reduce and see if it is stable in 30 degrees of flexion. We just let them do flexion and increase the range. If it is not stable in 30 degrees of flexion, more flexion is required. Then we decide either a Suzuki frame, or if it is reducing well, otherwise open reduction internal fixation. Does that summarize it correctly, sir?
That summarizes it correctly.
Yes, sir. And when you would say that this patient, at what duration would you say that this patient you will not take for a Suzuki frame and you would consider open reduction or a hemihamate or volar plate arthroplasty? Any specific duration is there?
Yeah, so in the immediate period, sometimes you have a depressed central articular fragment, which is gone in about 3 to 4 millimeters from the articular this thing. So in those cases, I find that even after you do the frame, that central fragment, although there are techniques of making a hole in the dorsal cortex and using a blunt wire to push it down, I find that it's difficult to do that. So in those cases, I will prefer to reduce the articular surface. So that means you need to open up. And in these cases, I will do a CT scan. So if the CT scan shows that the articular surface is very comminuted, then I would consider hemihamate. If the articular surface is not very comminuted, now this is very subjective, this very comminuted versus not comminuted. But generally, if it is in 2 or 3 pieces, I'm happy to plate it. But if it is shattered into many pieces, then I feel it is better to do a hemihamate, as long as the dorsal cortex is intact. That means it's not a pylon.
Right. Dr. Nilesh has a question. Nilesh, you can ask the question.
Yes, sir. So let's say that it's not a really bad involvement. The doubt is whether we should put extension block splint or extension block K wire. So they seem interchangeable. So whom should we offer wire? Because that means you need to take the patient in theater. Splint is something you do in the OPD and send them home.
Yes, sir.
I think the wire is invasive, but the wire is reliable in the sense that you can get the exact position. The splint needs some patient compliance. And so I think if it is an intelligent patient who understands what you're trying to do, I would put a splint. Otherwise, if you feel the patient is not compliant, it's better to put a wire. The problem with the wire is that you have to put the wire with the finger in maximal flexion. Otherwise, they cannot flex. The extensor tendon will get caught. It will prevent flexion. The wire will block the extensor tendon from coming down. So although the wire is not put in maximum, wire is put to keep the joint in 30 degrees, you have to flex the PIPJ to 90 degrees when you pass that wire. It's even better to make a longitudinal slit in the extensor tendon so that he can move in that range. That is from with the wire there from 30 to 90.
Yes,
in
sir.
our practice, usually we will end up fixing it, either putting a Suzuki frame or this thing. We rarely put wires. One of our fellows currently is from Finland, where they are like the pioneers of extension block pinning. And currently they are writing up on a 16-year follow-up of extension block pinning with excellent results. So they have good outcomes with extension block pinning. So I think in summary, if the patient is reliable, I think you can try extension block splinting. But if it's not reliable, then I think it is better to put a wire. The wire definitely corrects the subluxation.
I think one point what you brought out is a very important technical point, sir. We see some patients coming with extension block pinning done elsewhere and see they are not flexing at all. Because generally people who just maybe see the technique and do, they just flex to 30 degrees and put the wire. And then the extensor tendon is impinged in that and there is no flexion at all. So it is a very important point that when you are putting a wire, we should flex the finger fully, then put the wire. Though it is blocking last 30 degrees of flexion, but wire should be put in more flexion. Otherwise, the flexion will not happen. Yes, sir. Yeah, that is a very important point. Do you have any preference between hemi-hamate or volar plate arthroplasty, sir? Because many of the surgeons say that I open up for doing a hemi-hamate, but always finish while doing volar plate arthroplasty.
I've done two volar plate arthroplasties and they ended in disasters.
Yes,
so
sir.
I feel there is not enough volar plate to bring up and suture to the dorsal lip. It is very short in this injury, because when you're doing it, it's late, it's a contracted PIP, and then when you release it, I find that it is not. At least I have not had good results with volar plate.
Okay. You have any indications for putting a distractor? Do you, in chronic injuries, do you distract them and then do hemi-hamate, or you do at a single stage only?
I do at a single stage. Even if they come late, I will release the collaterals a little bit to correct the contracture and then put it a single stage.
Okay. You see any indications for doing a distraction at the PIP joint, sir?
No, I have not done distraction at the PIP joint.
Okay, sir. So actually last week we had a talk by Dr. Patankar, sir. So he was using distractors for most of the injuries. The results were nice, but we have not used much. So I just wanted to confirm what is the experience of other people. Sir, there is one question coming there, sir. Dr. Moideen. Yes, Dr. Moideen, you can ask your question.
Sir, thank you for a nice presentation, sir. Sir, you are not in favor of volar plate arthroplasty like that, sir?
Dr. Moideen is from Bangladesh, sir.
Yes. I have not had good results with it. So when I did it, I've done only 2 patients, and both of them eventually one ended up with a fusion and the other one didn't come back to me.
Okay, sir. Thank you, sir.
So theoretically saying, Moideen, what they say is if there is about less than 50% of the articular surface is involved, maybe volar plate would reach there. But if it is more than that, the volar plate would fall short, and hence it will result in more flexion contracture, and you will not get a good extension. So that is one reservation about it. So thank you, sir. So now we will go to the next paper, which correctly links to what we are discussing about the hemi-hamate replacement. And Dr. Sandeep also told is one of the preferred operation in chronic cases is hemi-hamate arthroplasty. It really is a very interesting operation for orthopedic trained hand surgeons. So they like to just place it perfectly and put screws. So it looks like a very nice, stylish operation. So we did few days back, and whenever we do it, it looks like it is a very interesting operation. But again, when we see the long-term outcome, patients' reports come as around 80 degrees of flexion. You again think like with a much simpler operation if you are getting the same result, whether it is required to do such a complex operation. Because hemi-hamate, though it is a nice operation, but at every step it requires to be done precisely. Otherwise, it would result in much more problems. So now Dr. Nilesh will talk about the second paper, which is related to the outcome of hemi-hamate arthroplasty. Nilesh, please share your screen.
Is it visible, sir?
Yes, Nilesh, yes.
Okay. So the article is the hemi-hamate autograft arthroplasty in PIP joint reconstruction, a systematic review. And it was published in Journal of Hand Surgery in the year 2015. And it comes from the University Hospital of Zurich. So the article again starts off by describing the injury pattern and the typical patient presentation and saying that it is a difficult injury to treat. The palmar lip, usually how much of it is got decides how much of stability is present to the injury. But the goal of treatment remains a joint reduction which allows early active motion. Now, multiple treatment options, especially for the unstable injuries, have been described with variable success, including open reduction and dynamic pressure system. And in 1909, Dr. Hastings described his technique of hemi-hamate the first time. And the ideal autograft, as he has described, should give good mechanical stability, a long-lasting anatomical reconstruction, and a minimum donor mobility. And this study tries to assess the evidence for hemi-hamate arthroplasty. So it starts off by describing the operative steps in brief, the Bolar approach, shotgunning of the joint, and what they do talk about is the risk of breaking the dorsal cortex while debriding the volar lip, and that can really complicate the procedure. After that, we measure the defect and harvest a similarly sized graft from the dorsal distal hamate and fix it with mini screws. Again, the article specifically talks about this step off that usually happens between the shaft of the middle phalanx and the what ends up being the distal end of the graft, and that can irritate the flexor tendon and hamper the gliding. And finally, we stabilize the joint by solar soft tissue repairs. So they recovered data from various databases like Medline, Scopus, Embels, and Cochrane. And initially, they were looking for all the papers related to the PIP joint injury. They found 177 paper, and 123 were not really relevant to the study at hand. So remaining 54 underwent the full text review, of which 41 were articles treating PIP joint injury by different techniques rather than the hemi-hamate. And the hemi-hamate pertaining articles were 13 in total. And the parameters for data extraction were number of patients, the degree of joint involvement, delay to surgery, how much was the follow-up period, the functional outcome, and the complications that were described. So this is the list of the case series that has been enumerated. So Dr. Williams was the first one to publish his results in a series of 13 cases with pretty good results. Dr. Kafi in 2009 came up with his series of 22 cases, which is probably the largest in 2015. And he added the step of extensor tendon tenolysis, especially in chronic injuries. And he also described that the results tend to be poorer in chronic injuries rather than the acute injuries. The series by Affendras et al. Reports good results in 8 cases, but they do report 1 case of osteoarticular osteoarthritis with screw migration in the joint needed to be removed. Dr. Korangail in 2011 published his series, and the different technique that they have used is they used a distraction, preoperative distraction for chronic cases to release the extensor tendon contracture. And post-operatively, they actually immobilize the joint for 2 weeks. Most of the authors have mobilized the joint within a week or so. But this series, they immobilized completely for 2 weeks and still ended up getting 90 degrees of arc of motion. The paper published by Yang in 2014 adds 2 different steps to the surgical technique. One is an oblique osteotomy of the autograft, which can help to recreate the volar lip of the middle phalanx. And the second is they repair the flexor anatomically. So they didn't try to create a soft tissue interval with soft tissue sleeve between the screws and the tendons. And the justification was there should not be any the flexor shear insufficiency. Lindenblatt are the same team that is reviewing the literature. They have published their own results of 10 cases, and they ended up doing surgery, secondary surgery for 4 of them. But overall results were good, and the rest of the 2 papers had single case each. Then they also talk about 2 articles about anatomical studies regarding the hemihammer. So this article in JHS 2008 did cadaverics evaluation of stability that is achieved at PIP joint after fixing the graft, and what happens to the carpometacarpal joint after we have removed piece of bone from it. So what they found is the PIP becomes quite stable immediately after fixation of the graft. They did find a statistically significant subluxation of the carpometacarpal joint. Fortunately, this probably does not translate into a clinical luxation because of the intact ligaments between the 4th and 5th metacarpal and the carpometacarpal. That's what the current paper says. There is another anatomy article by Dr. Rosen et al., and they actually did studies to see if we can harvest the hemihamate as a free flap. They did cadaveric dissection, and what they found is that you can harvest the graft as a vascularized graft. The pedicle is consistent enough to do this procedure as a free flap. And the authors of review article that we are discussing have done one case probably has been successful, and this the idea behind doing this is it might reduce the chances of future osteoarthritis. So in discussion, the article enumerates that in 2015 there were 21 cases that were described, and the procedure was effective in acute and chronic cases. And contraindications for this procedure was where dorsal cortical break, fracture of the head of the proximal phalanx, and already established arthritis before we do the procedure. The authors highlight certain technical and academic points. They highlight the need to develop the volar lip properly. If the volar lip is not recreated properly, then the joint is doomed to subluxate again. And one way of achieving that is instead of making a horizontal bed for the graft, if we make it tilted palmarly obliquely, then the graft would tilt automatically to recreate this volar lip. The other described technique is by Dr. Yang. So instead of making a cut of the graft that is perpendicular to the surface, they make a cut that goes obliquely. And again, this recreates the volar lip. In either of the situations, this step of need is to be anticipated and probably dealt with so that the flexor tendons don't get irritated because of it. In further discussion, the authors recommend the palmar plate repair. They recommend that dissection at the base of the flap of the digital neurovascular bundle should be avoided. Whether the immobilization should be partial or complete and how long it should be. So that is up for discussion. There is a paper which claims 2 weeks of complete immobilization still has good range of motion. Across the papers, the range of motion at PIP has been 77 degrees. That is all across the case series that have been reviewed, and distal interphalangeal joint ended up having flexion of 59 degrees. And authors highlight this point that patient need to be told beforehand that the distal interphalangeal joint movements are going to be affected. This is probably because of the extensor adhesions. The overall complication rate was 35%. That included even the minor complication. But the main complication that we would watch out for is the arthritis. And there are reports of up to 50% of X-ray changes of arthritis. How many of them are clinically symptomatic is not clear. The donor site morbidity has been reasonably low with no significant subluxation. The points to be still evaluated in relation to hemihamate arthroplasty is it cost effective when compared to other techniques like percutaneous methods of fixation? what really is the rate of long-term osteoarthritis, both clinically as well as radiologically? And does vascularized hemi-hamate arthroplasty provide a solution to the problem of long-term osteoarthritis? In conclusion, the authors recommend this procedure for chronic fracture dislocations. Thank you.
Okay, thank you, Nilesh. Sandeep sir. So this article is even more specific, taking only hemi-hamates and finally coming to, I think, the same value as you told, the 77 degrees. But one scary thing for a person who is deciding to do hemi-hamate, that every third patient, there is a complication. So is it really so a scary thing that every third patient you are going to get complication, or one can be more courageous and do it?
I think the 35% complication for hemi-hamate is reasonable. This is a highly technical procedure, and there is a very steep learning curve to this procedure. Also, it cannot be compared to the other procedures because the indications for this are different. I don't think anybody really wants to do this unless their hand is forced and none of the other options are possible, because it is just technically quite challenging. What I don't agree with the paper is that they say there's a 35% complication and then they say that it is a reliable procedure. I think it is not reliable. At present, we don't have any other choice for doing this procedure. There are no other suitable alternatives to do this, to provide the same outcome in a chronic dislocation. So you have this is the only choice now. So we have to suck it up and do it with the 35% risk of complication. The other option is to fuse it or do a joint arthroplasty. If there was any other simpler procedure, I would have chosen it without. And the guys who say vascularized hemi-hamate, I think without a pedicle itself, putting the graft there is so challenging. These guys who are talking vascularized, I don't know what they're talking about. That makes it like immensely challenging. Because putting a vascularized bone graft from medial femoral condyle, for example, scaphoid, that is already difficult because that one positioning the pedicle and making sure that the pedicle remains alive while you are putting a screw through the scaphoid and fixing it is very, very challenging. This pedicle is smaller. So I think that doesn't make, I don't agree with that. Secondly, the repair of the palmar plate, that also is not correct because you have to take off the palmar plate to do the shotgun approach. Then if you suture it back, there is nothing to suture. It is the hamate, which is a graft. You have to suture it to the cartilage or somewhere to the, so you are suturing it only to the side, to the collateral ligament to provide some accessory collateral ligament to provide some stability. So the takeaway for me is that I think the 35% complication is correct. This is a high risk procedure, but reliable or not, I don't think we have a choice when we do this. There is no equivalent procedure. The other one that is possible is the Japanese who have described use of a rib osteochondral graft to form the entire joint again, not just the base, but the entire joint again, with some units having good outcomes with it and others not so good. But most people keep that when the entire base of the middle phalanx is arthritic. For example, for reconstruction of a chronic pylon. In those cases, they use rib osteograft. But otherwise, when only 1/3 to 2/3 of the joint is gone, then of one surface of the joint is gone, then I think the hemi-hamate is at present the only available solution.
And even the vascularized, giving a reason that it would decrease the chance of arthritis also does not look like that much correct thing. That when you put a vascularized graft, chances of arthritis would reduce. So that is also not very nice. So since in this operation, technique is the most exacting thing what is required, I think most of our questions are going to be related to the techniques. So before I go to my questions about technique, we have one question from Dr. Nilesh. Nilesh, please ask.
Yes, sir. So couple of things. One is when I do it, I usually end up breaking the ulnar cortex of the hamate. I don't know, maybe I am doing it wrong or I have no idea. But how often I would say to all of you that do you end up, because the width of the hamate is not as big as the diagrams show. I have the whatever piece I need, it almost reaches the ulnar cortex of the hamate. That's number one. The other thing that I wanted to ask is any idea about the step of pushing the metacarpal volarly and then going into the joint and harvesting the graft the way the Yang paper has talked about. Does the metacarpal can be pushed so much volarly and we can go obliquely across the joint into the hamate?
Yes, Nilesh, that is the one point which I think we will ask everyone in the meeting and also Sandeep sir. So there is always a difficulty in taking that undercut. So what is your technique? Do you that the Yang, what they say that you can push the metacarpal down and take, that also is not that much easy. So is there any technique for doing that easily? And as Nilesh told about that ulnar part gets cut, even I heard one surgeon who is telling he intentionally cuts from the ulnar side, which allows you to take the lower cut more easily. So your comments on that, sir?
I use a curved osteotome, a small curved osteotome for the undercut. You can push it a little bit down. I think this is all different things that you add together. It is not like one dictum. So I think you push it down, you get an assistant, then and I make multiple K-wire holes on the dorsum before I use the osteotome. Sometimes the osteotome doesn't get into the right thing and it chips off. So I make, on the dorsum, I make multiple K-wire holes before I use the osteotome, and on the undersurface, I used a curved osteotome. I have not had the ulnar cortex break off, and I usually take a bigger graft than what is required so that I can contour it later on instead of sizing it exactly. But I don't, maybe I do 2 cases a year. So I don't do as many as that. We end up plating much more often than hemi-hamate. I only do hemi-hamate if I'm really forced to do it.
Yes, sir. I think Dr. Pankaj has raised hand. So he has also contributed to one video which we are going to release maybe tomorrow or day after on hemi-hamate. Pankaj sir, your comments on that and your trick.
Yeah, so I had a comment on Nilesh's question. Nilesh, what your experience is completely is in line with what I have experienced. The lateral cortex is very thin, and I almost always land up breaking it. Initially, I used to be very worried about breaking that cortex, but I think it just hastens the healing on the hamate that we have disturbed, and two, it allows us to make the distal cut much easier, as Praveen said. So I'm now not very concerned. As far as the problems of the graft are concerned, one of the major concerns that I have found is the ridge on the hamate not being in the center of the graft that we want to measure, because it really does not run perpendicular to the dorsal surface. Again, over a period of time, I've realized it doesn't matter. So even if I have a ridge which is articulating with one condyle of the P1, I'm really not bothered now. I think what is important is to take a nice big chunk of the graft and create a matching defect, make a nice large defect rather than trying to put a very small graft. I think that is a key to success of hemi-hamate. Take a large chunk of the graft and make a larger defect.
Sir, yeah. Before we go to the question by Dr. Amit, so 2 things about what you told, sir. You take that there is not much worry about both condyles matching. That ridge, center, and one condyle matching is enough. So that is a very important point. I think we'll become more courageous now, because I remember a few months back, we opened up the hamate and we saw the anatomy so much distorted that there was only one ridge and a condyle. Other side condyle was very concave. So then I checked in the literature also, they have described that there are a difference in the shape of the hemi-hamate, and some hamates are not suitable to replace the base of the middle phalanx. Has anyone encountered this type of case where they felt like the distal articular surface of hamate would not be suitable for doing a hemi-hamate? Since that case, we don't make a rectangular block into the middle phalanx base. We first go and see the hamate, and once the hamate is appropriate, then only come back and again prepare the middle phalanx base. Any comments by you, Sandeep sir or Pankaj sir?
No comments. I just agree with Pankaj that this is one of those situations where you match the bone graft to the defect, make a bigger defect. It's like cross finger flap. Don't take a small cross finger flap. The defect of the cross finger flap is already decided. Make the defect bigger. Of course, make enough bone graft, leave enough dorsal cortex for the screw purchase, but in general, make a bigger defect.
Yes, sir.
But
in attempt to getting a good size, sir, that the distal part of the graft, which always remains prominent, and we fear that it is going to irritate the flexor tendons. Is there any way to reduce that, or it is okay to leave it little bigger, no problem?
I leave it bigger. I don't think it matters.
Okay, sir. That is one concern which every time we have, whether flexor tendons are going to get irritated with that big piece. Amit, you have any question or any comments? Yes, sir.
Yeah, so about the prominence of the graft, again, I agree with Sandeep that I do leave a very large step off and it does not matter. I think what is important is a liberal A3 pulley flap, which does not force the flexor tendon onto this step off. So I go all, very close to the A4 and very close to the A2, and in fact maybe try and take a few fibers of both the pulleys as well. And of course, then to uh, cover that bony prominence with the A3 pulley flap. But take a good liberal A3 pulley flap, so where the flexor tendon is not forced onto this.
So one other technical point, which actually I learned from Pankaj sir while doing one case, intraoperatively, we should get full flexion, and you need to scrape off the extensor tendon from the base of from the dorsum of the proximal phalanx. So that is also another nice point, which many times we don't realize. So we just correct it and put. And once the hemi-emit is put, then you would see that it may be a little bit tight. So extensor tenolysis, scraping them off from the dorsum of the proximal phalanx also is an important step. So the important things are to take a larger graft. So ridge in center is important. On either side, having an exact match of the condyles maybe not so much important. When we are cutting the undersurface, we use all maneuvers, push the base down, use a curved osteotome to make the lower cuts. And if the ulnar cortex get cut, there is not much to worry about. So those are the important technical points what we get from this. Now, if our dorsal cortex breaks, is there any way out of that, or we should only go for fusion of the joint then?
I have not had it, but I think that is like a disaster. So I think when a disaster happens, I think we should just wait. I would put a frame and walk out, and then I won't harvest the hamate first. I think you need some time to think. Maybe you need to do a fusion, but I have not had this before. I would just put a frame and walk out for them. Yeah, Pankaj.
Yeah, unfortunately, I have had every conceivable complication of hemianate that you can think of. So let me share my experience. Usually the dorsal lip fracture will be a disaster if you have used lot of force while doing your shotgun approach. Okay, that should be an uncommon situation. If something which is going to require a lot of force, it means you need to do a little more release. Even with a very a delicate shotgun maneuver, you can have a chipping off of the dorsal cortex, which is not such a big disaster. As long as if you take a large chunk of the if you have created a larger defect and you have created a large graft, you may not be able to put screws right subchondral as you would want to generally if there is a the dorsal chip off, but the graft will still allow you to put enough number of screws slightly more distant. You possibly cannot break half of the middle phalanx while dislocating. It's usually a chip off where the dorsal periosteum is still intact. What it does is it delays your mobilization. So what I would have otherwise liked to immobilize in 30-degree flexion and allow active flexion, I just leave them in the position of rest for about 3 weeks. Explain to the patient that we would expect significant amount of stiffness because we had this problem, and then you have to work on both flexion and extension both. That's the only change that I have found would happen. But the dorsal lip really heals very well. It heals much faster than your hemihamate because it's a vascularized bone.
Okay. So I think Parag had that question and he'll be more comfortable now while doing hemihamate. So Parag, if as Pankaj sir says, if the dorsal cortex breaks, not to worry, we can fix the hemihamate a little bit more distally with more oblique screws, and that should be okay. In his experience, it has not resulted in very great disaster, though you will require to immobilize the patient for some more time. So a few more questions have come by, sir. One of the very interesting one is by Dr. Srinivasan. He says, is restoring palmar lip a myth?
For me, I think restoring palmar lip is the key to understanding PIP fracture dislocation. So I don't treat it like a myth. I think the palmar lip is what prevents subluxation, and either in primary fixation of PIP fracture of a PIP dorsal fracture dislocation, or in hemihamate, I pay a lot of attention to recreating the palmar lip.
So if sometimes, suppose your graft has come in such a way that you are not able to get the palmar lip, would you put some bone graft distally to lift it up like that?
Yeah, I would put some bone graft. We have something, we have Frutoplast, which is an allograft that's available. So I will use that to push it slightly forward.
Okay, so Dr. Srinivasan, the panel thinks that it is not a myth, and they stress a lot to get the volar lip. Even if we are not able to recreate, they'll put some bone graft to lift it up. Dr. Pankaj, yes, sir?
Yeah, so I would not be very perturbed if I do not see a perfect volar lip, as long as I see that the joint is gliding at the end of my fixation of the hemihamate graft. So I think that is the key. The joint should be able to glide without hinging onto the edge of the hemihamate. If it is hinging, then obviously you have put a very small graft. But really, there is no good measure of how much is enough. I have always landed up making the base of P2 much wider anteroposterior than what it naturally would be. And every time I look at the X-ray, I say, okay, next time I'm going to get it smaller, and I don't. In order to get that volar lip, I just keep putting bigger and bigger chunks of the graft. But I think as long as the joint glides, it's fine. Whenever I have put very small grafts and I was very unhappy at the end of the procedure, as long as the joint was looking congruous and it was gliding, it did not dislocate.
Okay, sir. Has anybody noted any donor site complication in hemihamate? This is another question which has come on the chat box.
None so far.
I have had loss of the knuckle.
Loss of the knuckle. Okay, okay. Why it was because of subluxation of the base, sir?
Yeah, some subsidence of the fifth metacarpal from a large hemihamate.
Another one question which again relates to the dorsal lip. If dorsal lip is broken, the central slip is gone, and there is a palmar subluxation. Any tricks for that? Dr. Pankaj only had the dorsal lip broken, so he only should be answering this, sir.
Yeah, so it's not as cruel a situation as you are describing. The extensor tendon insertion is a wide insertion on the dorsum. It's not just a rectangular piece of bone where it inserts. So even if the dorsal lip fractures, it does not displace the way the volar lip displaces. Okay, so it lifts off with a sleeve of periosteum, and therefore it has very good chance of healing.
Yes, sir. So though we have reached 8:30, but there are very nice, interesting questions, sir. I just cannot stop asking them. Sorry, Sandeep sir, we'll hold you for 10 more minutes. So one very nice suggestion has come by. So if you have had a dorsal lip fracture, why not put the hamate and then do a plating? Because plate is anyway going to hold on to the distal part of the middle phalanx. Nice suggestion, sir. What do you think about that? This again has come by Dr. Srinivasan.
I have plated for palmar fracture dislocations. I have plated from the dorsum, and those usually have a palmar fragment also. And if it's a large palmar fragment, you can plate it. But I think this is very situational. You're doing something else. You opened up, so that way your approach is only palmar or dorsal. Now what you're saying is you already opened up from the front, then you want to open up from the back. So when you open up multiple places, you have to be sure that the outcome you are going to get is good. I'm not so sure. So I feel that instead of making more cuts, I'd rather sit on it. There is no hurry to do it, like I said.
He is telling to put a buttress plate, sir.
Yeah, I know, but you already open from the front.
Yes, sir.
And then you want to open from the back to buttress it from the back. I think it's quite challenging.
Yes, sir. So maybe we can keep in mind. Thank you, Dr. Srinivasan. Very nice trick. Any role of plate if dorsal cortex breaks? Again, Rohan also has the same thought. There is Dr. Srinivasan still says that many times while doing hemiate, we are not able to restore that palmar lip, but I think we should try to get it at least, get it straight, not tilted on the other way. Otherwise, it will cause a dislocation intraoperatively itself. Then Dr. Hemant has asked, sir, what is alternative to poor screw hold on the dorsal cortex of the middle phalanx? Suppose you are not getting a good hold of the screw, do you consider doing a cerclage wire?
I have not done a cerclage wire. The cerclage wire requires you to make a hole and come through it. So it's quite, it is quite challenging. Then you have to be under the extensor tendon on the dorsum.
Pankaj sir, you anytime had an opportunity to do cerclage wire?
No, and a cerclage wire will require as good quality bone as would require a screw fixation. I think what we need to, I have had situations where I put a 1 millimeter screw and it did not have the desired hold. And then I would replace that 1 millimeter screw with a 1.3 millimeter screw. So there has been no other thing that has been required to improve the hold of the screw. It's important to drill bicortical and aim for a bicortical purchase. Don't be too worried about a millimeter of screw projecting on the dorsal surface. It will not irritate the extensor tendon because it is at the attachment of the extensor tendon. It is not under a gliding extensor tendon. So always aim for bicortical purchase.
So one
Do you
trick
put a lag in leg? Yes, sir.
Sorry, you carry on. You talk about the lag first, then I will say my trick.
Yes, sir. So do you try to put it in a lag pattern or no, sir?
Is it to me? No, absolutely not. I think it is already challenging enough to tell the nurse to keep changing the drill bit. Okay, well, my trick is this. I put K wires. For example, if I'm using a 1.3 screw and the drill bit is 0.8 or 1 mm, I will put a 0.9 mm K wire. I will put 3 K wires. And the trick during K wire is that I will hold the fragment down with the drill guide. So the drill guide is giving compression when I drive the K wire. Then I will drive all 3 K wires and replace each K wire with a screw. That's what I do. I don't use the other drill and screw because you can't keep it, you can't put a clamp and compress it because the dorsal cortex will break if you use some sort of a clamp to hold it. So I will keep it there. Sometimes the joint is subluxed. So you need to have your subluxation, the extension block wire maintained. Otherwise you're fixed. That is one of the reasons you don't get the dorsal lip correction, the palmar lip correction correctly. Because when you're fixing the hemihamate, sometimes you can get subluxation. If it's in a shotgun position, I will just pass multiple K wires hold it in position and then replace the KY with screws. If it is an extended position, then I will make sure that there is a K wire preventing it from subluxing dorsally when fixing the hemi-hamate graft.
Oh, frankly, I do attempt to make it into a leg screw.
Okay, sir. How many screws? 2,
Minimum
3,
3.
size?
Minimum 3.
Minimum
Either
3.
1 or 1.3.
1.6. Sandeep sir, yours?
I think there's basically a difference between orthopedics and plastic surgery. I think orthopedic surgeons like to go through the steps. Actually, one of my research papers now, I'm going to try and measure the difference in the compression cost at the fracture site between an interfragmentary screw and a lag screw. My gut feel is that there is no difference. But because we've been tortured by AO teaching for so many years that a lag screw causes more compression, we all believe that is better. But this is not the forum to argue that out. But I pass as 2 or 3 screws. Definitely 2. I think one to prevent rotation. So minimum 2, if possible 3.
Okay. Yes, thank you, sir. Very nice technical points. And listening to both of you, I think maybe I hope that our fellows also are listening, because few days back when I was doing the operation, I was having same apprehensions and they were feeling like, why this sir is so much worried about this operation. So, but this operation, actually every step requires some everything to go perfectly. And though having done many times, still every time one new type of challenge comes. But at the end, if everything fits nicely, it is a very nice, stylish and nice, comforting operation. So thank you very much. Thank you everyone for joining.
I just have one small comment.
Yes, sir.
If you allow me.
Yes, sir.
The more hemi-hamates one will do, you will end up doing lesser and lesser of those as you go on. You will end up fixing more and more fractures with their delayed presentations. So it's the hemi-hamate will give you the confidence to fix a good number of acute fractures in a complex situation.
So having told this point, sir, do you anytime have gone inside for hemi-hamate and you felt like fracture is fixable and you fix it?
Yeah, in last couple of years, more often than not. Where I've prepared for hemi-hamate, I have taken consent for hemi-hamate, and I have landed up fixing and just putting a cancellous bone graft from the Lister's tubercle to build up the articular surface.
Yes. Again, one point about the volar lip. I also felt, I think about 1/3 of the cases where we felt like we will do hemi-hamate, when we open, we see a chunk. If we are able to get that volar lip, the joint will become stable and we can move it immediately. So that is again a good point, sir. So still, when you are doing hemi-hamate, we can keep the option of internal fixation also in mind. And if it is fixable, we can build up with some cancellous bone graft and fix it. Okay, thank you very much, sir. Thank you. I think it is almost midnight now in Singapore, so you can go to sleep. Sorry to disturb you at this hour. Thank you very much. It was a great learning experience, and we got so much nice technical tips and also an overall view of what to do when we see a next PIP joint dislocation. Thank you everyone for joining. Good night. Thank you, sir.